Hey, welcome to Not So Complicated, and today we are discussing third clinical case, which is like this: a 52-year-old male presents to the emergency department with a 4-day history of worsening shortness of breath, dry cough, and intermittent right-sided chest pain that varies from dull to sharp with inspiration. He reports a low-grade fever, 38.0 degrees Celsius, and fatigue starting a week ago, initially attributed to a cold. His past medical history includes type 2 diabetes, hypertension, and a 15-pack year smoking history. He quit 5 years ago. 2 months ago, he was treated for left leg cellulitis with antibiotics. It is probably a case of cardiovascular system because it is associated with T2DM, hypertension, and 15-pack year smoking history. So let's go for the examination. BP is slightly raised, 145 by 90 mmHg. Heart rate is also raised, 108 beats per minute. Respiratory rate is also raised, 24 per minute, and oxygen is crashing, which is 87% is on room air, and temperature is 38.2 degrees Celsius. A long exam reveals scattered rhonchi bilaterally. Rhonchi indicates something low-pitched wheezes like that, and snore-like sounds on auscultation. Bilaterally, it indicates some obstruction in the airway, and dullness to percussion over the right lower lobe with no egophony. Okay, so egophony is the increased resonance of voice sounds when we are auscultating. So there is no egophony, and there is also dullness to percussion on the right lower lobe, which probably means there is a kind of effusion in there. And extremities show mild pitting edema in the left leg. Labs indicate WBC 14,000 per microliter, which is quite normal, and D dimer is 1200 nanogram per milliliter, which is elevated. The normal range is less than 500 nanogram per milliliter, and BNP, which is brain natriuretic peptide, 250 picogram per milliliter. ECG shows sinus tachycardia with incomplete RBBB. RBBB means right bundle branch block. We'll see the ECG in a later slide. And chest X-ray reveals a right lower lobe opacity and a small pleural effusion on the right. Okay, so what is the most likely diagnosis? Let's go to the options. The options here are pneumonia with parapneumonic effusion, pulmonary embolism, pneumothorax, acute respiratory distress syndrome, congestive heart failure, exacerbation. So we have to debunk each of the options. Let's go from eliminate and choose kind of way to tackle this question. So the option A is pneumonia with parapneumonic effusion. Let's debunk it. There is fever, there is cough, dyspnea, and chest X-ray opacity. Pneumonia is in the ring, but there is also dry cough. There is no egophony and bilateral rhonchi away from focal infection, right? So WBC is 14K fits, but fever is mild, and D-dimer is up. Effusion is also small, which means it is not purulent. If it was purulent, it would be termed empyema also. And CHF explains opacity better. There is no consolidation. Okay. So D-dimer test is also done for deep vein thrombosis, pulmonary embolism, stroke, disseminated intravascular coagulation. So one of the options is our pulmonary embolism. We might lean towards that too. And normal range is less than 500 nanogram per milliliter. No serious blood clot, and also elevated range is greater than 500 nanogram per milliliter. There is an active blood clot which indicates. So option A is highly unlikely. Let's go debunk the next option. Next option is pulmonary embolism, which is dyspnea, chest pain, oxygen 87% saturation, D-dimer 1200. So pulmonary embolism is highly likely. Cellulitis, histiocytosis, DVT, right? Deep vein thrombosis, but there is no pleuritic dominance either. No S1Q3T3, which is McGinn-White sign, as we talked earlier in our second case discussion, and there is just right bundle branch block. There is dullness, which is not hyperresonance, and bilateral rhonchi doesn't fit in here, but still this is a very high indication of pulmonary embolism. And there is edema and BNP 240 point cardiac, not clot, but still it can be a clot, because we have D-dimer 1200, dyspnea, chest pain, and also cellulitis, and chest X-ray opacity is fluid, not infarct. So seeing that MRI, we can see in normal, if the patient has pulmonary embolism, the MRI indicates like that, and this option is quite likely. Let's debunk the next option, which is pneumothorax. Pneumothorax is quite very unlikely because there is small right effusion in there, dullness in percussion also. So even if it is unlikely, let's debunk it. There is sharp pain and dyspnea, which teases it, but dullness and rhonchi kills it. There is no hyporesonance. There is no pleural line on chest X-ray. Oxygen saturation fits, but there is no sudden onset, no trauma. Trauma because if there was a rift fracture, it could cause pneumothorax, and also small effusion and edema scream fluid overload. There is no ear leak. Post-cold doesn't usually impact lungs. If there was if there was pneumothorax, the X-ray would look like this. You can see in the slide, and this option is very highly unlikely. Also, let's debunk the next option, which is acute respiratory distress syndrome. Oxygen saturation is 87%, bilateral rhonchi. ARDS could play, but there is no trigger, no sepsis, no trauma beyond the cold. Still, a cold is the trigger for ARDS too. So chest X-ray is unilateral opacity, not diffuse infiltrates, because ARDS generally presents with diffuse infiltrates, and like the X-ray I have attached in there. And the fever is low, WBC 14K is mild, cellulitis is resolved, there is no systemic crash, BNP 250, and edema leans towards heart. It is not a lung flood, so it is very quite unlikely. The last option is congestive heart failure exacerbation. Debunking it, dyspnea, oxygen 87%, bilateral rhonchi, pulmonary edema fits, right-sided chest pain, dullness, effusion. Also, congestive heart failure causes pleural effusion. We all know that, and it causes fluid overload, obviously. And there is a history of hypertension, T2DM, smoking history, which raises the cardiac risk, and also brain natriuretic peptide 250 is elevated. There is leg edema, right bundle branch block, which causes right ventricular strain in there. Chest X-ray opacity indicates edema. This is not any infection, so post cold tipped it. So this is very highly likely, so I'm gonna go with the diagnosis of CHF exacerbation. So on a side note, there is an interpretation of natriuretic peptide levels in special situations in a table attached. The causes of elevated natriuretic peptide levels other than congestive heart failure can be left ventricular dysfunction, previous heart failure, advanced age, renal dysfunction, acute coronary syndromes, pulmonary diseases like ARDS, lung disease with right heart failure, and pulmonary embolism, high output states like sepsis, cirrhosis, hyperthyroidism, atrial fibrillation, and NP levels lower than expected occur in obesity, flash pulmonary edema, heart failure etiology upstream from left ventricular. Example, acute mitral regurgitation, mitral stenosis, cardiac tamponade, and pericardial constriction. These are the interpretation of natriuretic peptide levels in special situations. It is high yield for USMLE PLAB. So our diagnosis is CHF exacerbation. CHF exacerbation simply means that heart cannot pump, fluid backs up. So fluid is backing up in lungs and legs in here, and the types are left-sided congestive heart failure or right-sided congestive heart failure. If it was left-sided, it causes pulmonary edema, and if it is right-sided, it causes edema plus jugular venous distension, and this is mixed dyspnea plus leg swelling. The case is 4 days back, so it is worsening from 4 days. It is of post-spiral stress plus chronic hypertension or diabetes mellitus tipped it. The figure in right side here is normal ventricular chambers are there in the normal heart, and in congestive heart there is thickening of the ventricular chambers and a smaller filling capacity and ejection of the blood. So what are the causes of congestive heart failure? The causes can be hypertension, which causes left ventricular hypertrophy, or type 2 diabetes mellitus that causes ischemia. Smoking causes vessel damage, systolic or diastolic dysfunction, and viral upper respiratory tract infection demands spike, heart just failed. That is the cause in here, and the result is left ventricular pressure increased, which caused pulmonary edema. Pulmonary edema caused the symptoms dyspnea, rhonchi, oxygen saturation 87%. This is the pathophysiology, and also right ventricular strain caused leg edema, effusion, and brain natriuretic peptide is 250, which means cardiac stress did that, and the time is 4 days slow decompensation, and it is now acute. The effects of cardiac congestive heart failure on the body are presented in a figure sideways. There can be coughing, tiredness, shortness of breath, pulmonary edema, pumping action of the heart grows weaker, pleural effusion, which is in our case in right basal lobe, and also swelling in abdomen, swelling in ankles and legs can also occur. So what are the signs of CHF exacerbation or CHF are rhonchi, edema, effusion, fluid overload. They all indicate fluid overload. And BNP greater than 100 indicates that cardiac or heart is very much stretching. And also the ECG shows right bundle branch block that caused right ventricular strain, which is not specific. There is no ST elevation MI, but ischemia is possible. It is not specific, but also associated. We can see in the ECG right in the right side, AT is with 3:1 and 2:1 conduction. Also in the left side of the ECG, there is LAFB, which is left anterior fascicular block. And also the imaging shows chest X-ray opacity, which indicates edema or effusion, echo, which causes ejection fraction to be down, and wall motion is the key. And this guy has BNP 250, chest X-ray opacity, echo stat, because we have to rule out ischemia in here. And the management of this case, if it was acute, which is oxygen saturation should be maintained over 90%, and diuretics should be given like furosemide, because there is fluid overload and we have to decrease the fluid, and nitrates should be given to unload. And to work up, we have to do echo for ejection fraction and bulbs, and also troponin should be analyzed from blood if it was a case of MI or myocardial infarction trigger. And if the case was chronic, ACEI, S inhibitors or angiotensin converting enzyme inhibitors should be given in hypertension case, beta blockers for heart rate, and statins for vessels, which also fix we also have to fix diabetes mellitus in here there. And in this case, we have to give Lasix. Lasix means furosemide, and oxygen, dig into hypertension control and savage pump. The congestive heart failure treatment is also in the right side attached in here. General measures are treat underlying cause or precipitating factors, diet modifications, adequate rest, mild exercise, alcohol and smoking cessation, adequate oxygen, and health maintenance, obviously. But the medications are diuretics, S inhibitors, angiotensin receptor blockers for hypertension, and beta blockers, cardiac glycosides for heart failure. Cardiac glycosides like digoxin or digitoxin should be used. And also, if it was surgical, we have to do revascularization, angioplasty or cavage, and valve repair or replacement. And device therapy, we have to do cardiac resynchronization, biventricular pacing, and implantable cardioverter defibrillator. We have all these ICD indicators. ICD-10 indicator is usually done in CHF exacerbation. And the prognosis of this case, there are risks of arrhythmia, recurrent failure, renal hypertension, and also diabetes mellitus upwards. And stats, 50% is 5-year mortality post exacerbation is in there. So of note, the NYHA classification, New York Heart Association classification of congestive heart failure, we have 4 classes. Class 1 is no symptoms and can perform ordinary physical activity without limitations. Class 2 is mild symptoms and slight limitation of physical activity. There are no symptoms at rest. And class 3 is marked limitation of physical activity even with less than ordinary activity due to symptoms and comfortable at rest. Class 4 is unable to carry out any physical activity, severe limitations, symptoms present even at rest. So this is it. This is our third case discussion, and subscribe for the next case discussion. And if you want anything to be covered up, you can comment and I will pin it up and I will try to cover it up. So thank you.